Hello, welcome to today's webinar, EvidenceNOW, Insights for State Health Policymakers on Advancing Evidence-Based Primary Care. I'm Jennifer Reck, Project Director at the National Academy for State Health Policy, or NASHP as we're known. This webinar is supported through a collaboration between the Virginia EvidenceNOW Cooperative and NASHP to share findings from EvidenceNOW with state health policymakers. A couple of quick notes on webinar logistics before we begin. You should be able to stream the audio for the webinar through your computer speakers, or you can call the number listed on the slide in front of you. We have more than 125 registrants for today's webinar, so audience lines will be muted during the duration of the webinar. Please make sure you don't place your line on hold, as hold music might disrupt the speakers. You can ask a question by typing it into the chat box at the bottom left of your screen at any time during the webinar. We will respond to questions both through the chat box and during the Q&A at the end of the webinar. And following the Q&A, please take a quick minute to complete the evaluation. And finally, a recording of this webinar will be made available on NASHP's website within the next few days. Today's webinar will be a panel discussion with speakers from 3 EvidenceNOW cooperatives who have kindly offered to share their experiences, lessons learned, and insights for our audience of state health policymakers. To start things off with, I am very pleased to introduce our moderator today, Dr. Daniel Carey, Secretary of Health and Human Resources for the Commonwealth of Virginia. Dr. Carey joined the Northam administration in January this year and has been at the forefront of professional health care in Lynchburg, Virginia since joining Cardiology Associates of Central Virginia in 1997. Dr. Carey held numerous leadership positions at Cardiology Associates and later at Centra, a health system that acquired Cardiology Associates. He most recently served as the Senior Vice President and Chief Medical Officer for Centra. In this capacity, his responsibilities included information technology services, patient quality and safety efforts, performance improvement initiatives, and the functions of the medical staff at Centra's 3 acute care facilities. In addition, Dr. Carey was the system lead for Centra's implementation of its new electronic health record. And Dr. Carey has a special interest in medical leadership and has served as president of the Lynchburg Academy of Medicine, the Medical Society of Virginia, and the Medical Society of Virginia Foundation. Dr. Carey graduated from the University of Virginia and Harvard Medical School. So thank you very much for moderating today's call, Secretary Carey. I will now turn things over to you to introduce EvidenceNOW and our speakers, please.
Great. Thank you so very much. It's indeed a pleasure to serve in the role as moderator. Before I introduce today's panel, I would like to provide a very brief overview of EvidenceNOW. The Agency for Healthcare Research and Quality EvidenceNOW Grant Initiative is a federal investment of $110 million to 7 regional cooperatives spanning 12 states and reaching more than 1,500 small to mid-sized primary care practices. The focus of the initiative is to use evidence to improve the ABCs of heart health to prevent heart disease, recommending aspirin for high-risk individuals, blood pressure monitoring, cholesterol management, and smoking cessation. Next slide, please. For our discussion today, we are pleased to be joined by representatives from EvidenceNOW cooperatives in Virginia, Oklahoma, and North Carolina. Dr. Curtis Elward is a member of the faculty for the Virginia Cooperative, known as the Heart of Virginia Health. Dr. Elward is a physician leader with extensive quality improvement and practice transformation expertise and is a seasoned clinician with over 30 years of full-spectrum family medicine. His quality improvement successes range from innovative work in office-based quality improvement initiatives to leading community-based performance enhancement projects. He is board certified in family medicine, internal medicine, and geriatrics. A graduate of the Improvement Advisor Program at the Institute for Healthcare Improvement, Dr. Elwood's special interest is in process improvement and change management for medium and small practices, as well as on the front lines of large health systems. He completed a fellowship in primary care research and received his MPH in health services research from the University of Washington. He graduated as a James Scholar from the University of Illinois College of Medicine. Next, we have Dr. Stephen Crawford, co-director of the Oklahoma EvidenceNOW cooperative, known as Healthy Hearts for Oklahoma. Dr. Crawford, a family medicine specialist, has been in practice for more than 36 years. He is the Legislative Committee co-chair and a past president of the Oklahoma Academy of Family Physicians. He has also served as the chair of the Commission on Government Advocacy of the American Academy of Family Physicians and as a delegate to the Oklahoma State Medical Association to the American Medical Association. Since 1995, he has served as chair of the Medical Advisory Committee of the state's Medicaid agency, and in 2016, he was appointed as the physician member of the Oklahoma Hospital Association's Board of Directors. He graduated from the University of Illinois College of Medicine. And finally, we are joined by Ms. Anne Lefebvre, part of the North Carolina EvidenceNOW cooperative, Heart Health Now, Advancing Heart Health in North Carolina Primary Care. She has served as the Associate Director of the North Carolina Area Health Education Centers Program at the University of North Carolina at Chapel Hill and oversees statewide quality improvement efforts for North Carolina's AHECs. Included in her responsibility is the function of Executive Director of the North Carolina Regional Extension Center, as well as directing the Improving Performance and Practice program for the state of North Carolina. In this role, she has developed a program to train and support over 40 staff to perform as consultants in over 900 primary care practices across the state to assist in the adoption and use of technology to improve quality. Additionally, Ms. Lefebvre has an adjunct faculty appointment in the Department of Family Medicine at UNC Chapel Hill, and has previously served as faculty for the Institute of Healthcare Improvement on the Primary Care Practice Coach Professional Development Program. Thank you all for joining us today and agreeing to serve in this role. Next slide. We will now have a chance to hear from our panelists in response to our first question. What was your cooperative's approach to advancing evidence-based prevention? Kurt, could you go first, please?
Yeah, thank you. And thanks, everyone, for being here today. We started in Virginia with presenting the overall evidence base for our measures at our kickoff, which we encouraged our participants to attend. It was a way of them getting to know us and us getting to know them. And then taking the principles of evidence-based prevention, particularly the ABCs, we conveyed specific strategies for implementing the basic elements. And I would say basic is not simple. Basic is how to get started and how to build on success. We also realized the multiple pressures we were under, or they were under, and really tried to focus on what would be most helpful for them. We listened to their experiences and attitudes towards evidence-based guidelines. What was their experience in the past? What were their challenges? And where could they actually take specific first steps to target the evidence-based guidelines? There are some differences in different measures out there, but we tried to use our kickoff to get those sort of addressed, where we could focus on shared principles and make sure everybody was on close to the same page and understood what the evidence base was, what the updates were. We also presented these evidence-based guidelines from a primary care point of view and the ways the project could help them achieve key measures of success. And we did that by framing it in terms of optimizing the individual patient visit while improving efficiency, and we presented them with what I would call positive practice case examples. And that means how were people able to use their staff? How were they able to make it fit within the many other things they have to do? And how can they actually prepare for building on to incorporate the evidence-based prevention guidelines overall. We focused on simple approaches to process measures. There are some outcome measures that we looked at, but we really referred to the rich database that is available on the effectiveness of these measures, and focused on the key elements of these guidelines as part of the process of care. And we looked at how they could be more easily incorporated into the stream of care for a given patient visit. Now, from previous collaboratives, we realized the importance of taking care of the practice first and dealing with stressors, problems with efficiency, the way they use their staff as a team as they work through the project. And I would say, as we'll talk about later, this was really critical to not only engagement, but their reception of the goals of the project and the value it had for them. We also offered several pathways to implementation of these guidelines and could tailor those options to their practice situation. So one of the other things we tried to do was just make sure that the evidence-based now measures served as key markers, and they were very, very helpful. So I'll turn that over.
Perfect. Anne, if you could take a swing at that, please.
Sure. Here in North Carolina, our initiative was a collaborative effort between the University of North Carolina at Chapel Hill, Community Care of North Carolina, and the North Carolina AHEC program, which are the area health education centers here in North Carolina. We recruited 250 practices into the initiative. Each one of those practices was then introduced to the concept of practice facilitation or a practice coaching program. Each practice was offered and received 12 months of intensive practice facilitation from a highly trained and really effective professional that is steeped with knowledge in, ambulatory care and process improvement, workflow redesign, quality improvement techniques, as well as a lot of change management and culture pieces that come into this work for ambulatory care practices. After their 12 months of intensive intervention, they were also offered an additional 12 months of a maintenance with that same coach to continue the work that they're doing. We focused our work in 6 key areas. One was leadership within the practice setting, engagement of that practice with our coaching program, the clinical information systems in that practice and how to use those EHRs to generate the data needed to help them understand how they're moving and improving in these areas, the adoption of care-based protocols, and the self-management support that the patients need in order to really improve heart health, and then also optimizing the care team within the practice. By focusing on these areas with intentional change packages for the practice to move through, we really targeted the measures used across the nation in this initiative, and we were able to see some really great success in the results, in the health outcomes for these patients, but also in the satisfaction of the practices and staff as well.
Terrific. Terrific. Thank you. And now, Stephen, could you address that question as well, please?
Sure. The first thing that we had to do was attempt to identify all of our primary care practices in Oklahoma. We didn't have a existent database of all primary care practices, so we developed that and I think it's a valuable resource for things going forward. It obviously changes rapidly, and then we assembled a group. We hired a group of people to be practice facilitators, and that we went through a robust training program for those practice facilitators and practice improvement like the other cooperatives did. We also hired some part-time, what we called academic detailing or peer coaches, clinicians that would go out and help instruct the practices in the new guidelines. We used a multi-organizational effort to do all of these things. We were centered out of our Oklahoma Clinical and Translational Science Institute. That's a multi-institutional institute based here at the OU College of Medicine campus, but it involves not only our college, but the School of Community Medicine in Tulsa, our Oklahoma College of Public Health, the Oklahoma Foundation for Medical Quality, our existent HIE in the state called My Health, and we also contracted with a group called NARCAD, the National Resource Center for Academic Detailing out of Harvard, to assist us with this. The latter helped us develop academic or peer coaching aids to go to the clinicians to instruct them in the process of practice improvement and the guidelines. We did on-site practice facilitation, QI support, along with support for developing their EHR. So we didn't require them to have a particular EHR, but we worked with them to assist them both with developing their EHR to do quality improvement and also to connect with our HIE in the state so that it would be able to obtain that data. We also were able, as I know the other cooperatives, to provide one of the benefits to the participants, continuing education credits and maintenance of certification credits that also assisted them in these efforts. We also looked at improving their financial security and hopefully their joy in practice by doing all these types of things, and it seemed to be productive in doing that. Thank you.
Well, very good. Thank you, Stephen. Now for our next question. What challenges or barriers did you face in your work, either anticipated or otherwise? Anne, can you go first with this question, please?
Sure, I'd be happy to. I think all three of us faced similar and many challenges in this work. So I'll take the first one, which is probably the easiest one. I know all of the cooperatives faced was a challenge in producing the data that was needed for the practices to understand where they were currently performing and then to show any improvements that they were making. In North Carolina, our program at the AHEC was the regional extension center for the state for reaching meaningful use. We had a lot of depth in our knowledge in electronic health records, and our partners at Community Care of North Carolina likewise had a lot of knowledge and background in informatics and pulling information from electronic health records. And we, anticipated problems in this area, but we sure were faced with more than we really understood that we were in for, as did all the cooperatives across the country. Again, we had connections to the EHRs to get the data directly from the electronic health record systems, and we were challenged with different EHR interfaces from different vendors, getting those interfaces set up and useful. Our biggest challenge was really getting normalized data so that the data was it in the right place within the electronic health record with where it was supposed to be, and could we find it? Was it in there in a standardized fashion, and was it something that we were able to pull out and really stand up for the practice to look at and use? We had to be really creative and work around a lot of that. We used any type of reporting that we could out of the electronic health records for meaningful use reportings and clinical outcomes reportings that a lot of the vendors use in a lot of different ways. We finally were able to get some data for the practices to use, but we certainly, as a country, have a long way to go in the use of data for ambulatory care practices, that's for sure.
Very good. Stephen, could you be next, please?
I would emphasize Anne's discussion of the data issue, what I call data non-integration. It is truly a challenge and not helpful in regards to trying to improve the quality of care, particularly in smaller practices all over our state. We also dealt with the issue of practice disruption. There's a lot of primary care practice disruption going on. It could have been present all along, but it's certainly something we experienced, that we'd get a practice enrolled and then they would get moved or they would close for whatever reason because of the frailty or the difficulty in maintaining primary care, at least in our rural areas around the country, around our state. We also dealt with the issue of excessive research related demands, that because this was a research project, there was, and not just a quality improvement, it required a variety of other interventions and techniques to get around or to work with that particular system, so that it made it somewhat artificial at times in what we had to do in this particular project, because the hope was to use this as a test to see if this effort, even as limited as we could, or we were able to do, it still was a challenge to get around all the research-related demands. And there were some other regulatory hurdles, too, that we had to deal with, particularly, obviously, HIPAA and other issues, and the systems issues, I would say, is the big one. If there were a practice within a larger system, because we went out we have a variety of large healthcare systems, including we went to a variety of Native American tribal health systems. And again, getting access into those, they were wanting to participate, but you had to jump a variety of hurdles to get into their system and have them cooperate. So those are the types of things that we had barriers with. But in the end, I think we were able to get a reasonable number of practices to participate. It's just at times there's so many demands on primary care right now that adding another demand on them seemed to be in some ways challenging for many of our practices. I'm finished.
Very good. Go ahead. Excuse me. Kurt,
yeah,
I think you're next.
Yes, I would echo all of Ann and Steve's comments about EMRs. I would say that there might be an opportunity for state policymakers to advance the cause of uniform measures and interoperability for population health and prevention measures, and to work with clinicians and health systems, as well as EMR companies, to create some standards and expectations for being able to share data, really for the good of the public health. In some ways, you could do that through state registries already with vaccinations, prescription monitoring programs. But the EMRs, I think there's a long way to go with those. In Virginia, actually, our major advantage, among some others, was the use of our QIO as coaches. We used their coaches on our project, and they actually brought in a lot of experience in EMR support to the groups. So they were immediately valuable for a number of things that the participants needed. One of the things that we really saw as a barrier, and I think we addressed it, was to teach them how to streamline care and how to use their staff, because there's a lot of physician and staff burnout and discouragement. Many excellent and caring docs are completely overwhelmed by the pressures of regulation, insurers, disjointed reporting obligations, and we really tried to use our project to help bring them along with that, show them how to be more efficient, and we found that they were really energized. And while we didn't, make everything go away, so to speak, we really empowered them and helped them understand how to use their staff and how they could be far more effective and address their internal barriers as well as the external barriers that they have to deal with. I would say another barrier that we found, which we hope we're starting to address in Virginia, is the distance sometimes between primary care and public health at the state level. Our Commissioner of Public Health, Dr. Levine, has been a real leader in how you blend primary care and public health collaboration, and we try to use our project to advance that and hopefully do so more in the future.
Very good. Thank you. I think we're up to our next question, and there's our next slide. Very good. What are the key takeaways you and the team learned that could help states better understand effective models, tools, interventions, and/or policy levers for advancing evidence-based intervention? David, if you could start us off.
Okay, thank you. I would say there's a couple of things that I would like to emphasize. The first is the more practice facilitator time in practice, the greater the effect. We found that weekly visits of 4 hours for the 6 months was pretty effective at helping practices improve. But it really is a dose response curve. They have to feel integrated into that system to be able to have an impact when you're providing it from an outside source. Again, we were providing practice facilitation like a part-time employee, and we knew that we were gaining ground if they were allowed to come in the back door rather than the front door, the employee's entrance, and that was a real plus when that happened, when they felt like they were part of the team. We also feel like there's a real need for states to develop collaborative agreements to align and coordinate the various organizations that are involved in the attempt to practice improvement. Again, as I mentioned in my previous primary care, and most healthcare is being inundated by demands for doing this and doing that, and it's not very coordinated. From the academic health centers to the QIOs to the regional extension centers for meaningful use. All of those are, and let alone now the federal government CMS demands on MIPS and MACRA types of things, though they're very appropriate for them to coordinate those, but you're also getting it from private insurers and others, and then the systems are also wanting improvement and so it's not very coordinated, and you get these continuing demands on a practice situation that's kind of hanging on by the threads, and you add one more demand on that and they break apart unless there's adequate support for that, and it really destroys that joy in practice that in the end we're wanting primary care to go out there, but they're not getting the support they need.
Very good. Thank you, Stephen. Anne, your thoughts on this question?
Yeah, I think we learned a lot in this process all working together. I think a key takeaway in that we had in North Carolina and other states as well was really the use of the practice facilitator to coach the practice in adopting new evidence. And so one of the key areas that we all worked on was cardiovascular disease risk indicators. And these risk calculators have been out, I think, since 2013, maybe 2014. So this wasn't necessarily new evidence, as in it was just published for the study that we were working on. It'd been out for a while, but we found that really by putting a practice facilitator in the practice to help them redesign their workflow so they could really use these risk calculators with the patients as an educational tool and a real motivator for what could the patient improve in their lives to reduce cardiovascular risk, it was just a great way to really push that evidence that was out there, help the practice get on board with a similar protocol between all of their providers so that the staff could really be engaged and motivated to really support patient care. So it was really the use of the practice facilitator and how that can be used to be put out into a practice to advance evidence and I would say even advancement of policy when you get into the programs that we're moving into now with MIPS, with patient-centered medical homes, with meaningful use and things like that. Just having someone help these practices by coaching them through these things.
Very good, Anne. Thank you. Thank you. The next slide, please.
Well, Dan, I can make a couple comments real quick.
Okay, go ahead.
I would echo exactly everything they've said. Don't assume that the health systems or insurers have better ways of doing this at a primary care level, and don't assume that EMRs are an answer to population health problems. They are an aid, but we really came to the project believing in the innate capability of the teams and helping them grow that capacity. And that is a very powerful lesson that we, I think, had learned and validated. Bringing some help to them and their staff has been really important. Their health as a primary care system and their capability are really keys to success. And states that have expanded Medicaid or are contemplating this should consider creating coalitions to provide this kind of practice support. And that's something that I think North Carolina understood years ago. And so we recognize the tremendous challenges primary care clinicians have in just adding one more thing, but coming alongside them was very, very powerful and has motivated them to continue their collaboration with us.
Very good. Very good. All right. We'll move on to our next question then. Where do each of you see, or where would you like to see your state going in the future based on your experiences in EvidenceNOW? Kurt, why don't you go ahead and go first this time?
Yeah, thanks. Well, what's really a great opportunity in states that have done this project is that there is an incredible network of real-world primary care practices and coaches that have experience and tangible success in transforming the way they approach chronic care, as well as prevention and public health challenges. And there's a tremendous opportunity, I think, for collaboration with state health policymakers. We hope that there can be a much more robust partnership between primary care and public health to address leading causes of premature death, disability, avoidable hospitalizations in our Commonwealth, and to address areas such as obesity, diabetes, and the opioid crisis, and do that with nurturing systems that approach that can involve health systems and payers as well as policymakers. Using our network and those in other states, I think there's a really great opportunity for states to address key issues, including optimizing efficiency and capacity in the Medicaid population and using this model to encourage greater participation and satisfaction with the Medicaid program and ultimately improving their outcomes.
All right. Thanks, Kurt. Ann, your thoughts?
Yeah, I absolutely agree with what Kurt just laid out there. I think using this network of healthcare professionals, of practice facilitators who are really knowledgeable about the demands that are placed on ambulatory care practices, using them on both sides. Come and ask us, how you think this policy will be received in primary care practices. We've worked in more than 1,400 practices in the last 10 years in the state of North Carolina. I would love to help, really kind of plan rollouts for policy and those types of things. And then on the flip side of that, I would love to use these types of practice facilitation programs to go out into practices and educate what new policy is coming and how can practices redesign the work that they're doing to meet those policy requirements, so that we don't just expect practices to jump up to meet those policy requirements, but we actually give them an educational background and an on-site training so that they can understand, just like with new evidence, practices have to understand new policy and how to enact that policy within their practice. And I'd love to see the existing networks that we've built for practice facilitation to be used for policy.
Very good. Stephen, your thoughts?
Yes, excellent points by both Kurt and Ann, that the ultimate goal is hopefully financial and regulatory support to develop a sustainable infrastructure for primary care practice facilitation and improved data integration that's going to involve multiple QI partners, multiple funding sources with a capacity to support both the funder-initiated and the practice-initiated quality improvement that we're all looking for. So it's going to require like a new professional that everyone recognizes we do, that there's a valuable practice facilitator role that hadn't really been defined in our healthcare system until relatively recently. It's been out there, but it's not been as well defined, and it's a professional role that we think we should continue to enhance and improve and develop the infrastructure, both for the professional development of those folks, but also to assist practices and being able to access them, just for what Ann and Kurt had mentioned.
Very good. Very good. Thank you, Stephen. And as intended, we've allowed a robust amount of time so that we can field questions from our audience. And I want to thank our panelists for the questions answered up until now, although we'll have more questions from our audience. And I'll turn things back over to Jennifer for audience question and answers. Thank you.
Great. Thank you, Secretary Carey and our panelists. Excuse me. At this time, we invite you to join the conversation by typing your questions or comments into the chat box at the bottom left of your screen, and we will share your questions with the panelists. So we'll just hold tight just for a moment to give people a chance to raise any questions that they have. And actually, I will, while we give people a chance to do that, I will throw out a question to our panelists, please. Oh, wait, hold on. I will hold that thought. We just got a question here. The question is, can you say more about ways to strengthen the collaboration between public health and primary care? Are community health workers one way to do this?
Well, this is Ann in North Carolina, and I'll take a quick stab at it, but and then I will defer to my colleagues as well. As the area health education centers here in North Carolina, we also work with community health workers. I think that is an interesting field that is burgeoning as well. It's growing as well. There is a distinct difference between practice facilitators and community health workers, and I think that's important to understand. Community health workers may or may not be trained professionals, and they work to support the practices to work with patients and help them understand and meet some of their needs in both education and resources and things like that within their community. Practice facilitators are highly trained individuals to really help to re-engineer ambulatory care practices to meet the demands that we're looking for in a transformed healthcare system. I think that a practice that has both a practice facilitator and the use of community health workers is making a great use of the resources available and the new healthcare professions that are coming up through, and I do think that those practices probably will go a long way in new models of care, but those two fields are very different.
Yeah, this is Kurt. One of the things that I do think is really exciting for the use of community health workers is to really fill in the gaps that between when the patient leaves the office and when they get home, or once they are home. We have several districts in our state that are actively using community health workers to reach out to at-risk individuals, people with educational issues or transport issues, and that has been very, very helpful, particularly in empowering the care plans that are part of our the primary care physicians, how they develop those, but really creating a more seamless process of care in the community. So I think that's a great resource to try to bring to the table.
If this is Steve Crawford, if I may, one of the things we've been attempting to develop is essentially what Ann called the extension center model that was based on the agricultural extension model from 100 years ago, to put essentially extension centers in every county, a county health extension program that we call CHIOs, County Health Improvement Organizations, that would help bring together people such as the primary care providers, the hospitals, the pharmacists, and community health workers and the public health system to work together to identify areas that they need to address, that they can go after grant funding to go to do something that's important for their particular county or counties. If there's fairly, in our area in western Oklahoma, it's sparsely populated, so some counties would come together. But that type of thing to help support a robust extension system that very much like the AHECs have done in some of our states around the nation.
Okay, thank you to our panelists. I see another question has just come in, and the question is, as a result of your connection with primary health care, would you have an opinion as to a basic minimum set of self-evaluation processes helpful for maintaining its level of quality? I guess that the question is getting at just basic markers or indicators for our practice in terms of quality.
This is Anna. Go ahead, because I went first on that.
Okay. All right, thanks. Sorry. We're on the same wavelength. I think that there are a number of things that we've learned through this collaborative, or the different collaboratives across the country, that will be coming out as to which will address that specific question. And it will involve both some assessment of how you structure your office staff, what kind of care needs are there, what kind of capacity you have in your reporting system. Unfortunately, a lot of the EMRs were sold as billing and coding tools, but I think one of the things that will be coming out of our project will be, across the country, will be a better clarification of what really is needed in your data sets and EMR capability to get the job done on key quality measures. The other thing I think we are learning is that while you have to make sure you have good software and you make sure you have durable hardware, you need to take care of what I call your liveware, which means how do you, what kind of capacity do you need in personnel, and how can you ramp up your staff. That does not particularly mean hiring, advanced level practitioners. We found several practices that took some of their medical assistants and taught them how to do specific skills in terms of quality tracking, evaluation, that could really complement all the clinicians in the office. And that was a very wise investment on their part. Many practices don't do that. So I think, in answer to your question, I think there are some key measures that we are identifying as a result of the project, and I think they'll involve a lot of really internal practice structure.
Yeah, so this is Ann, and I would add to that. I 100% agree with what you just put out there, and I would add to that really looking at disruptions. I think primary care right now, in addition to having additional burdens placed on them for care delivery, I think the disruptions that come into the practice are something that we need to really focus on. Disruptions such as moving from one electronic health record to another, possibly disruptions in ownership, meaning that it may be owned by one health system and now they're changing to ownership by another health system, and then certainly the disruptions with turnover in staff, which get to what was just said. But I think that those disturbances in the practices, if they can be minimized, or practices that have not had as many of those disturbances, make greater gains in the work in this area, especially when working with a practice coach or facilitator.
I would concur with both Kurt and Ann. The other practice disruption that is insurance disruptions, when insurances change processes for getting patients appropriately referred to clinical needs such as imaging, or particularly, and it happens, and it's a big deal, is medication pre-authorization. That seems to be a bugaboo, particularly at the beginning of every year. The patients change insurance and they've been on a particular medicine for years, and then they have to go through a whole rigmarole, every practice does, to pre-authorize or get authorization for the use of particular medications that really, in many times, doesn't make a lot of sense. It just is very, very disruptive for a practice to have to do that every beginning of every season in January. You really don't want to be in a primary care practice in January during that period of time because it's a real bugaboo. And that's, and if there's a major change from the Medicaid patients to any commercial insurer, that really causes a lot of heartache and angst for many clinicians and their staff.
Yeah, I would add to that, Steve, that one other thing that I think there's a real opportunity on, and I'm not one for over-regulation, but in one area of our state, the health system realized that they had to report on 312 different measures when they aggregated the asks from insurers, because many of them wanted the same measure in different ways. And while there's some respect that has to be had for their proprietary, for their autonomy and their role, I think there is a real role to think about shaping policies so that there are some uniform reporting measures for particularly preventive care, and that those can be reported out of an EMR in a standard fashion across insurers and ultimately to inform state health policymakers. I think that would really, really help, and we've seen a lot of those duplicative reporting requirements really slow down the process of improvement and impair the quality care that people can get. So that's, I think, one really good opportunity.
Okay, thank you, panelists, for those responses. We'll move on to our next question. In any performance improvement initiative, there is an initial investment of time and effort, and then later benefits accrue as the system improves. Was there a predictable time before the practices started to feel benefits of the effort, and were the practices more similar, or did they vary all over the board?
I'll try it first. This is Steve Crawford. I would say the latter, that they varied depending upon where they started, their particular facility and the use of their EHR, their prior experience with practice improvement. And I think, though, if they did allow the practice facilitator to come in, it took, as I mentioned earlier, there's really a dose-response curve to that, that it took several months for that to have an effect. And again, ours is ended at the end of a year of intervention, but I think that the hope would be that it would continue, but I worry that since we're not able to sustain it at the moment because there isn't a sustainable infrastructure, that so many of those gains may be lost.
This is Kurt. One of the things that I would also echo, and what we've really tried to do throughout this project, but several other prior projects over the last 10 years, is come in and immediately create what I would say a value proposition or an optimized practice proposition, so that we could go in and say, for example, look at the way they're seeing patients and help them more efficiently see a couple extra patients a day, organize planned visits more effectively. There are some people that really lose a tremendous amount of money because of their inefficiencies, and we tried to go into the practice and look for those and look for efficiencies in how they were using their EMRs so they could bill more appropriately for the services they're providing, make sure that they're capturing the care that they give in documentation so they can justify that. I would say to implement some of the basic things took about 3 months to fully implement and fully see some of the benefits, but we really pushed hard in our practice to show how much value, what I see is how you can get paid for your performance just by doing the right thing. Many practices in Virginia are not under value-based contracts yet. But we found a number of situations where just a few differences in staffing, a few differences in organization really turned into better bottom lines and more efficiency for them. The turnaround takes a few months. because you have to change some schedules. You have to, really help them through the process. But it doesn't take a year. I think we were starting to see some changes within about 3 months, and we tried to focus on small changes so they could immediately see that and then continue to build on it.
Yeah, I would just add to that. I think we agree. We saw different changes with different pieces of the project. I do think some of the process level changes, such as aspirin therapy or prescribing statins, I think those process changes can happen more quickly than the actual blood pressure values reducing over time. I think as far as sustainability of the work goes, that's true on that level too, is when you're able to change the processes in a practice and how the practice behaves and functions, that can be sustainable if it's put in well and tested well throughout the process. But lifestyle changes from the patient's perspective and things like that will always be challenging and will always need to be continually monitored and sustained. And I think that that's why the work is so challenging, is that it has a lot of different angles that it needs to take. And the practice has to be truly ready to sign on and evaluate their own processes and how that impacts patient care. And until they're ready to do that, it's challenging. And that's one of the hard things that came in with studying this work, was when the study is ready to move doesn't necessarily mean that the practice is ready to move.
I would say one other thing, Ann and Steve, is that we, as a collaborative and with the number of practices we have, we were able to really share examples of what people were doing that was making them more financially viable. And whether they're in a system that expects a certain amount of production, or whether they're in private practice where they have to, pay the bills, we were able to share some really, really innovative thoughts, and also help them understand some of the insurance changes, although that's not what the project was originally designed to do. But we realized that there were really some ways of doing group visits, for example, that people had wanted to do and could make financially viable that they hadn't been able to do before. The key to that, however, was to share what really hardworking, innovative docs can do if you give them a chance, and getting them to communicate.
Okay, thank you all. We'll move on to our next question, which is one about EHRs. The question is, what kind of policy opportunities do you see for mitigating integration issues with electronic health record systems?
Yeah, I'll try to take a stab at that. I think one of the challenges is that many systems have some investment in making it hard to transfer data, and that even with some very, very large systems that may sell to 5 hospital systems in the state, it won't always be the quote the same version, and there are really exorbitant charges that are foisted upon physicians and their health systems to make them interoperable. From a policy level, I feel pretty strongly that there should be some guidelines in a state that are sort of the cost of doing business. Just like if you have insurance companies in the state, health or otherwise, they have to report on certain measures. You have to be able to transfer data in ways that make sense. I think that there's a role for a renewed conversation, maybe sometimes the first part of the conversation, on if a large EMR system is going to be doing business in the state, they have to make some of their key elements interoperable, and I think everybody can be on the same playing field. I realize that is a challenge, but I do think it's tremendously important, and it probably has to come from a state policy level to be effective. But I think you would get a ton of support from the health systems and actually patients when they realize that they don't have to, when their information in one system is actually available in another system.
This is Steve Crawford. I would definitely concur. The EHR vendors are holding our data captive to payment of almost exorbitant prices to get that data shared for the purposes of practice improvement. It's not them that own or put in the data, it's the clinicians and their staff that do that, and it's really the data really in many ways is the patients, and I think there needs to be some sort of attempt to, like we do in some states where you have a unified vaccine record so that we can look that up. There really needs to be a unified health information exchange capability that EHRs can't hold a practice hostage to the added cost of that that are needed. If we're going to do practice improvement, if the system wants that to happen, they can't hold the primary care clinicians who are, again, are a low-margin business to try to afford to do that without some support.
Yeah, I agree with everything you said. The question around the policy piece behind this, I think, is the really interesting part of it. I think the points made already about, can we really use policy to drive effective exchange of data, I think is where we need to go next nationally, and whether that's state-based policy or federal policy or probably a combination of both. I think that this was tried some previously with the National Certification Program for Electronic Health Records, but I really think that there are big portions of that fell down or didn't have the teeth to begin with, and so you have a lot of electronic health record systems out there that are, quote, certified, but the data isn't ready for exchange or transmission to a unified platform. So I think that using policy to drive that next piece of it is going to be critical.
I would put a couple cents in about the collaborative, the network of practices we have might be a good testing ground for what elements really can be used across different EMRs, and that's just another opportunity that I think our groups have to offer.
All right, thank you, panelists, for your response on that one. We have another question, and we only have 2 minutes left, but I think this is a briefer one. Were the primary health clinics of your regional medical schools involved in your project?
So this is Ann in North Carolina, and I can tell you that we did have a very small percentage, but some of the clinics involved with 247 practices. And off the top of my head, I would say we might have had 8 to 10 practices that were affiliated with academic medical centers. That doesn't mean that they were residency training programs, but that they were affiliated with academic medical centers.
Yeah, I think we had a couple, but a couple of the larger medical centers had already been doing some quality improvement work, and so they just weren't. They had other projects going on. So most of ours were not academic.
We had several of our academic practices, both in Oklahoma City and Tulsa, participate. The challenge is that academic practices, particularly, and we tried to involve residents, is that there are so many other competing demands. It's very difficult to do this particular type of project, not quality improvement per se, but one that is added on to many others that are going on already. So they did participate. It was somewhat chaotic compared to a full-time practice, but we were dealing with that particular issue regarding practice disruption all over the state too, just more so in a academic setting because of the part-time nature of both faculty and resident practices.
Okay, thank you all. We are at the hour here, so I would like to once again thank all of our speakers and our moderator and for today's participants for sharing your questions. Thank you all for joining today's webinar. You'll see a link on your screen to a NASHB brief which will share more information with you about Virginia's EvidenceNOW cooperative and their experiences if you're interested. And as I mentioned at the beginning, if you could take a moment to fill out the brief survey, we would appreciate it very much. Thank you all and have a good afternoon.
Thank you.
Thank you.